Thank you so much, everybody, for joining this nationwide bladder cancer Q&A webinar. And for our amazing nurses on the call, today is International Nurses Day, so thank you very much for joining. We're so lucky to have a brilliant panel of bladder cancer health experts. It's a privilege to have them all with us today. So it's a wonderful opportunity for us to get those questions that we all have answered and to learn more about bladder cancer. May is Bladder Cancer Awareness Month, and we at Beat Bladder Cancer Australia have been trying to do our bit to raise awareness to the Australian public and to provide support to those impacted by bladder cancer. It's been a huge month for us, as well as this landmark Q&A webinar. We've launched bladder cancer support groups across all Australian states and territories. And later this month, watch out for a very exciting awareness campaign promoting blood in your pee, see your GP. But without further ado, start what should be a very interesting Q&A. Thank you very much.
In the higher risk cases where it is high grade and we think the chance might be that it's a 50-50 of coming back without further treatment, BCG seems to reduce that by approximately another half. So maybe it's 50-50 without treatment, it might be down to more like a 25% chance of it coming back with treatment in the high grade cases. Most of the cases we see where it does come back, it's usually in the bladder, although there is a slight risk of it coming back in the other areas, so the ureters or the renal pelvis are higher up towards the kidney, because that tissue is exactly the same as what's in the bladder. So that's still also very important in the surveillance and the follow-up, not just the bladder, but to also think about surveillance of the ureters and the kidneys. And that might mean that a CT scan of that area is done from time to time as well.
Thank you, Patty. Karen, as a stoma nurse, you may see some patients that may present with urinary tract infections after BCG, which is very common. So what are some of the symptoms that patients may experience with urinary tract infections? And also, how do patients go about getting a urine specimen to help the doctor make a diagnosis of a urinary tract infection?
So I guess when we're looking at urinary tract infections, there's a few key things we look for, or the patient would look for. Cloudy urine, sometimes foul or pungent urine smell when they're emptying their pouches, if they have a stoma. Also probably pain in their back. They may have just the normal flu-like symptoms of feeling a bit joint pain. You know, they might have some blood in their urine. That's another symptom we see. Also, they can just feel like they've got a cold or flu kind of symptoms, just very basic. I guess from taking a sample from the stoma, the best way to do it is definitely not take it from the end of the bag that's been on all day, your pouch that's been on all day. The best way is to actually remove the pouch if you have a ileal conduit, and actually just clean it like you normally would clean it, and then just get the clean urine specimen, the little pot with the yellow top, take the top off and actually just try and drip the urine into the little pot without actually touching the inside of it. That probably gives us the best and cleanest specimen possible to collect it, if we don't have the ability to come in and see one of the stomal therapy nurses to actually take a sample from the conduit itself, which we do a little catheter insertion and take a clean specimen. But the best way to do it if you can't come in and see a stomal therapist is actually just to try and take a cleaner sample as you possibly can.
Thank you, Karen. Patricia, one more question for you. A lot of patients complain sometimes of pain or discomfort after receiving BCG. Is there any treatment available to relieve some of those symptoms?
Yeah, the symptoms are really very common of irritation of the bladder, because I guess that's kind of what the treatment's trying to do, is to irritate and inflame the bladder to make your immunity kick in. So we actually do like if you get a few side effects from the treatment, because it means it's more likely to be actually working. The main treatments, I guess, are similar to treating urinary tract infection. So making sure you have plenty of fluids, you can use Urel or cranberry tablets, cranberry juice. If you're getting kind of bladder spasm or pain, it might mean that you need some painkillers, or some of the anti-spasmodic agents that try and reduce that kind of contracture of the bladder. And sometimes it means we need a break from treatment if it's really building up and you need each other toilet multiple times at night. Sometimes you'll need a treatment, and very rarely might need to take a steroid tablet like prednisolone to reduce that inflammation. But really, the majority of people get very mild symptoms of a bit of irritation and burning, and we explain that that's part and parcel of the treatment. And we hope that that's a positive thing, that it means that it is actually working and taking the simple measures of the fluids and the Urel work for the majority of patients.
Patricia, a question has come in from Heather asking, how long is too long for BCG treatments to be delayed? And with chemotherapy, they say 4 to 6 weeks start post-surgery is ideal. Is there a window with BCG treatment effectiveness?
Yeah, I guess we don't like to start too close to the cystoscopy. So there's a risk if you've got an open wound inside the bladder that some of that BCG could get absorbed into the bloodstream and affect somewhere else in the body. So you want those little scabs and wounds in the bladder to have healed. So we don't treat within 2 weeks of biopsy, so 2 weeks after cystoscopy, or if there's ongoing bleeding, we would wait for that to completely settle. But in terms of the delay, I guess there's not really an optimal time, but we're trying to fit it in between 2 check cystoscopies. So most of the time someone will have a cystoscopy to show that the cancer's there, and 3 months later there'll be a checkup cystoscopy plan. So we ideally like to fit it in the middle of that. So there's also still a break between the end of the 6 weeks of the BCG and the next cystoscopy. So I guess we most commonly would start it around about that 3 to 4 weeks after the cystoscopy, but it's not a disaster if it happens to be a little bit more delayed than that, because we can always just negotiate with the urologist about maybe delaying the next check cystoscopy if it's getting too close to the treatment.
Okay, like I said, lots of questions coming in for BCG. It's a very popular topic in our support forums. How many UTIs between treatments should you have before treatment is stopped, before another alternative treatment is offered? If there is another treatment, what would this be? That comes from Judy.
Some people wouldn't get urinary tract infections at all, so the majority probably don't. If they do maybe one episode during their course of the BCG, and normally that means we would skip that treatment where they're presented with symptoms or pain, give a course of antibiotics, and 90% of the time you're ready to go ahead the next week with just 1 week off.
There was another question for you. How long can I realistically keep going with BCG installations together with surveillance cystoscopies with the resulting granulomatous inflammation and scarring from the repeat biopsies? Also, my first TRBT resulted in a bladder rupture. I've had 7 courses of BCG and 16 cystoscopies in the last 5 years. I'm a female, 55 years old, and otherwise healthy and fit. So that's a question. How long can she keep going on with BCG for?
I guess that sounds like a very long time and a lot of cystoscopies in that period of time. But I guess if we kind of guess that someone would have a maximum probably 4 cystoscopies in a year, so 16 over 5 years would be quite close surveillance. So maybe the patient who's asked the question might have had a few recurrences and needed treatment a couple of times. There isn't a magic number of how many treatments you can have, because some patients can go on for years and hardly have any long-term side effects at all. But we know that the more treatments you have, the more likely it is that the bladder can start to shrink and cause scarring so that your volume that you can hold of urine gets less. So what tends to happen over time is that you go into the toilet more and more frequently and unable to hold urine for a long time, and possibly getting a little bit of urgency and less warning about when to go to the toilet. So I couldn't say there's an exact number of treatments. I've had a couple of patients who have had treatment on and off over that same kind of time period, and have tolerated it quite well, and we dictate when to stop and when have you had enough based on what symptoms you're getting. Although it is concerning about the bladder rupture in that this is obviously getting a lot of scarring of the bladder, and I've been nervous about treating again after that.
Professor David Gillett, when would you say surgery would then be the next step after BCG?
After BCG, well, there's a small number of people who've had treatments like BCG who, it is a small percentage whose bladders are damaged enough by itself to warrant surgery, but that's a very small minority. In terms of the cancer, obviously a failure to respond to BCG, the cancer comes back, particularly if it's coming back quickly or despite BCG, is a poor prognostic feature, and that could be one reason for considering early removal of the bladder. So I think that's why, like Paddy said, you've got to really emphasise how important it is to monitor the bladder during and after treatment, because persistence of high-grade bladder cancer, early recurrence, failure to respond to BCG can all be signs that the disease isn't fully controlled, and therefore maybe indications for moving on to other treatments, including surgery.
Okay. Anthony had asked if BCG treatment can be used for low-grade tumours, but it's if I'm correct in saying it's only for high-grade tumours.
There's no advantage over standard chemotherapy for low-grade tumours.
Yeah, I mean, we occasionally use BCG even in low-grade if there's been multiple recurrences over a short period of time. Ideally, we try to go for a chemotherapy agent into the bladder instead, and most commonly would be used as a drug called mitomycin C. However, mitomycin C is not funded by the PBS, so you kind of get a little bit stuck where patients either have to self-fund for the drug, or we approach their private health insurance if they're insured, or we have to ask the public hospital if they're willing to pay for the mitomycin. But in terms of the evidence, what should we use is probably using a chemotherapy agent and reserving BCG for people who've got the high-grade disease.
All right, Pat, let's give you a break and let's ask Professor Manesh Patel, urologist, surgeon, robotic surgeon. A patient has recurrent tumours even after 2 failed BCG inductions plus an induction and 12 months maintenance of doxorubicin over 2 years. Initially diagnosed with 3 high-grade tumours, but now has a recurring low-grade tumour. Would repeated low-grade tumours be considered a reason to undergo radical cystectomy or just to continue doing TURBTs?
Interesting case, Cully. So this patient's had a lot of BCG and probably more BCG than most patients would normally have. If they've had 2 failed BCG inductions, that's probably a time where you've got to question whether BCG is actually going to work for this patient. And yet they carried on having BCG. I suspect the patient's probably not very healthy, and that's why they didn't have a cystectomy after the first 2 inductions and carried on having more BCG. Low-grade tumors is not a reason to do a cystectomy. There's other options available, particularly intravesical chemotherapy. And if that fails and they get further high-grade tumors and the patient is unfit for a cystectomy, then there's also a number of clinical trials that we can do that the patients possibly can get enrolled in.
Okay. I have a question for Amy next. Is grade 3 localized invasive cancer curable with only chemo and radiation? And what are the chances of recurrence and what's the remedy?
So yes, radiation combined with chemotherapy is an alternative to cystectomy and can be a curative treatment for muscle-invasive bladder cancer. Radiation is given as a daily treatment where you have 1 treatment each day over a number of weeks, usually 4 to 7 weeks, and that's given combined with chemotherapy. The likelihood, the aim of that is to cure the cancer. Not all patients who have a muscle-invasive bladder cancer are suitable for a bladder, what we would call a bladder preserving approach with combination chemotherapy and radiation. But for some patients, they would have a choice, and it can also be a really good option for people who may not be well enough to undergo a radical cystectomy. The other important part of the treatment is more limited surgery prior to the chemotherapy and radiation. So that would be what we would term a TURBT, where the bladder tumour is resected from inside the bladder during cystoscopy to reduce the tumour volume prior to proceeding with the radiation and chemotherapy. The likelihood of getting rid of the cancer completely with treatment really varies depending on the stage of the cancer, but on average, the chance of getting rid of it so that there was no visible tumour when you have a cystectomy after the treatment's been completed is often around 70 or up to 85%. One of the important components of a bladder conserving approach, similar to the non-muscle invasive setting, is ongoing monitoring. So after you've completed treatment, there is a program of regular cystoscopies and checkups to identify if there's any evidence of cancer which has returned. And if there is cancer which does come back in the bladder, it may still be then possible to have a cystectomy for some patients. Over time, the likelihood of something coming back within the bladder after treatment, again, varies a lot, but the risk of an invasive recurrence returning is probably in the range of 15 to 20%, with an additional risk of developing some non-muscle invasive recurrences as well.
Thank you. As we know, I mean, radiotherapy can come with some kind of side effects. Are these long-lasting side effects?
So there are side effects that you get during treatment, and the commonest ones would be tiredness, irritation of the bladder, where you might get symptoms similar to a urinary tract infection, frequency, urgency, or some pain when passing urine, and some irritation of the bowels. And there may also be some side effects associated with the chemotherapy. In the longer term, after treatment's finished, a significant majority of patients have a good quality of life related to their bladder function, but some patients can have some impairment of the bladder function, with a very small proportion of patients, again, needing a cystectomy if the bladder is not working well after the treatment's been finished. If the bladder wasn't working well prior to radiation, where someone had a lot of frequency or urgency, that might be a person in whom trying to keep the bladder is not the best idea.
Thank you, Amy. Just a reminder to everyone, and thanks again for joining us. If you do have any questions, you can type them in at the Q&A bubble at the bottom of the screen. Moving on, we had a question all the way from New Zealand, which was directed to Professor Manish Patel. I hope they're still awake in New Zealand. The question goes, we are in the position now of follow-ups after T2 invasive bladder cancer was treated with chemoradiotherapy last June to August. My husband has had 2 cystoscopies, one at the end of November and another in the middle of March, both clear. He was told he would have another in June and then go 6 monthly for checkups. Is that normal to go 6 monthly after only 3 monthly checks? He also had a CT scan in January, which was clear. He was told there'd be no more CT scans. Is this normal? That's the question from New Zealand. Cheryl.
So there are a lot of different protocols on how to follow patients up after they've had chemoradiation. Probably the most common protocol that's used is from Europe, from the European Society of Urology. And what they would normally do there is 3 monthly cystoscopies for 2 years, 6 monthly for another 3, and then yearly after that. And they would also have repeat CT scans, probably every 6 months. I can't remember the exact protocol, but every 6 months generally for the first 2 years, and then yearly after that until you get to 5 years. That's a general, more or less, protocol. But again, you know, everyone might follow a different protocol, in which case there's probably evidence behind it. Amy wants to say something as well. So I can't tell you what protocol this urologist was following, but it's not really quite the one that I do.
Yeah, so the only comment I was just going to add, completely agree with everything that Manish has said in terms of the recommendations from EAU or the NICE guidelines in Europe. The one situation to consider is if someone was not going to have a radical cystectomy, if there was a recurrence within the bladder, sometimes it's very, very reasonable for the surveillance protocol to be less intensive if you would not progress to a cystectomy if a recurrence was identified.
Thank you, Amy. Well, let's move away from chemotherapy and radiation. Let's talk a little bit about surgery. So I'm going to move back to Professor David Gillett, a urologist and surgeon, also does robotic surgery. The question says, when deciding on having a urinary diversion. So basically, once your bladder has been removed, and this is for muscle invasive bladder cancer, T2 and higher, what are your options for now, because the urine has to get out somehow. So what are your options for a urinary diversion? So please, can you explain in what situation each of the options are recommended? And does age play a part in making a decision on which option should be selected?
Yes, I think first of all, you're quite right. The treatment for the cancer is the removal of the bladder. What you do about the plumbing afterwards then it has a number of options, and I probably wouldn't use the word recommended. I think this is a discussion you have with the patient along with the specialist nurse and whatever other members of your team are present about the pros and cons of different ways of dealing with storing and getting rid of the urine after the bladder has been removed. In most cases, I wouldn't firmly recommend one option. I would go through the benefits and lack of benefits to the patient. And the first thing I'll say is there are sometimes you can firmly recommend against some options. For example, a neobladder, which is constructing a pouch from the intestines and putting it down onto the urethra, requires a functioning and healthy urethra. So somebody who's already got continence issues or damage to the urethra isn't suitable for it, usually. If cancer is affecting the edge of the urethra or even the bladder neck, that might be a relative contraindication, as you may have a higher risk of recurrence. A bladder reconstruction has some limitations. I think it's a good option, particularly in younger folk. I've operated on people up to the mid-70s. You've got to have somebody who is prepared to go through a period of retraining of their bladder and continence re-education. Urostomy is probably the commonest, by far the commonest option in most Western countries, where you form a stoma and the urine drains through a small piece of bowel into the skin directly. Often said to be simpler. It's at times it's got its own issues, but you need to certainly have a very competent and skilled stoma team behind you, because the patients mainly have issues around their skin and the bag, occasionally with peristomal herniation. So I'd see this as two options you discuss with the patient and try and find the best one for their lifestyle, their needs, and occasionally recommend against one of them if it's not suitable. The third option is to create a pouch and use something like the appendix to bring to the skin, and it stores the urine, and the patient has to catheterize through the skin to drain it every 3 or 4 hours. And that's a good option in somebody who wants to avoid a stoma but is not suitable for a bladder reconstruction. And that's something I used to do quite often about 20 years ago, but very much less frequently now, because I think it's one that you have to have somebody who's very committed to looking after that. So you have to have a team behind you, and it's probably got more of an impact on quality of life than a neobladder, than a bladder reconstruction. So a continent cutaneous diversion has got limited indications, but is excellent for a very small number of people, as long as you've got the right support behind them. So I wouldn't recommend any of them. I'd discuss the options and hopefully have a nurse team and others behind us to go through the pros and cons of each option for the patient.
Claire had said that she was receiving BCG and she had a recurrence at the neck of the bladder. Does that preclude her from having a neobladder?
You're asking me? Yes.
Yes. Sorry. Yes.
Well, generally, if you've got tumour at the bladder neck or the urethral margin, yes. However, I need to see what the type of recurrence was, when it was. If it's a low-grade recurrence a while ago and the operation's coming much later on, it may not entirely do so. But in general terms, tumour in that area would be one thing you'd have to think very seriously about not doing a neobladder in that situation. The Manish would agree with that.
My take is slightly different. It certainly increases the risk of recurrence in the urethra, but I usually would do a frozen section of the urethral margin, and if that's positive, they certainly can't have a neobladder. But if that's negative, and the patient understands the risk that there is a risk of recurrence in the urethra, I'd still go ahead.
So you would say earlier cystectomy is better than a later one?
You're asking me again? Yes.
Yep.
It depends. It depends what for. I mean, there's evidence with high grade, more aggressive, superficially invasive cancers, the ones that in fact treated with BCG, that if you delay definitive treatment over a period, and these are for non-randomized trials, that the outcomes are less good. So I think if somebody keeps getting recurrent tumours despite treatment, my view is that they should be thinking about an earlier cystectomy, because delay for too long will probably affect their prognosis in the long term. So what you call early cystectomy, I still think it's better to give them a fair go at BCG and follow-up, but if you're not getting the response you want, that's the time to discuss moving on to the next option.
Manish, the same patient, Claire, has mentioned she has duplex ureters. So for anyone that doesn't know, that's 2 ureters draining into the bladder. Would that affect having a cystectomy done?
No, absolutely not. It's quite simple to implant both those ureters into the near bladder or ileal conduit or whatever diversion you're doing. Doesn't really complicate the operation much at all.
Claire also asked, having removed the bladder, is there a chance that cancer can return in the rest of the lining of the urinary tract up the rest of the ureter and the kidney?
Absolutely. So the same lining as the bladder goes up to the ureters into the pelvis of the kidneys on both sides. And the cancer in the bladder is actually a field change. So a lot of the urothelial cells that go all the way up the kidneys have the same damage as what there was in the bladder. So the recurrence rates are there. They tend to be much lower than in the bladder and somewhere between, say, 2 and 5% in the upper tracts after a cystectomy, but it's still there. So we do need to keep on keeping an eye on those areas.
I'll switch back to Professor Gillard. A question came in as, what is the best treatment for a parastomal hernia and what effects may it have to a patient, and is a surgery necessary?
Parastomal hernias are relatively common around all forms of stomas, not just ileal conduits. Some series, it may be as high as a third. It doesn't mean to say they all need treatment. And I think the first step with an ileal conduit is, again, to have the support of an excellent stoma nurse and team, because they can often manage some of the hernia. If they are getting bigger, however, and they're painful or there's any sign of obstruction, they probably do need surgical correction. And that's in a smaller percentage, but a parastomal hernia can occasionally trap bowel, can cause some obstructive symptoms, can cause pain, and very occasionally the abdominal wall muscle can start to give way, and the hernia can get quite big and heavy. So those are reasons for fixing it, but the majority will be managed in conjunction with our stoma colleagues.
So, Karen, that brings us to you. Any practical advice you have for someone that might have a parastomal hernia?
I think prevention is always the first step. So most of our patients that have an ileal conduit or any form of stoma, we normally get them to come back and see us post-op, and often we will measure them up to fit a stoma support garment. There's different degrees of those. Probably my go-to would be actually a belt if the patient is, wanting a good support, because that's the strongest support that you're going to get. Basically, we, in the post-op phase, we really instill to them no heavy lifting in the first 6 weeks. If you can't lift it in one hand, you can't lift it. If you kind of make it simple, then, hopefully that will encourage patients not to do a lot of heavy lifting. And I just, for us, good exercise is always good. So increasing, core exercise, but not in the immediate phase post-op. But we encourage them to wear their support garments when they're doing any form of heavy lifting or activity, even things like gardening, pulling out the garbage bins, easy things like that. It's still a lot of stress on having, the parastomal area as well.
This patient has asked, when will your clinics be up and running as normal? Specifically you.
Glass, I don't know, magic crystal ball would be what we need at the moment. Unfortunately, due to the COVID, we're really put in the middle of nowhere, so it's quite difficult, but we still will see our patients where possible. We just have to find an area, I guess. Yeah.
a question back for Professor Gillett. Given the current pandemic and the reduction in elective surgery and treatment of conditions, what has COVID actually had an impact on treating bladder cancer patients?
Well, I doubt if it's had an impact at the moment in terms of prognosis, because it's not been on long enough. But I'm quite concerned about this. Certainly, data from other countries like the UK is that probably as few as 10% of people who used to present within 2 weeks with symptoms of cancer, like blood in the urine, are now presenting to those fast-track clinics. People are staying away from the clinics, and we've certainly seen a noticeable drop-off in patients attending our clinics. So the first message is, if you've got blood in the urine, it still counts as an urgent symptom. You should get it investigated. We're all trying to prioritise the urgent cases, and high-grade bladder cancer and blood in the urine are both considered Category 1 urgent cases and are being dealt with, hopefully, still as urgent cases. But there is a danger if the elective shutdown goes on too long that some of those cases will start to slip. And there is, as I've said earlier on, some evidence that the higher grade bladder cancers do suffer detrimental effects on their prognosis if left too long to be treated. So we've not seen it at the moment, but the knock-on effect would be the problem. What's happening 6 months down the line if it went on too long?
Thank you. We've spoken a little bit about surgery, and we mentioned neobladders. It's not a secret, but Christine is a person that has had a neobladder. So I'd like to ask her, how has her life changed now that she has a neobladder?
Well, I've been living with a neobladder now for almost 3 years. My radical cystectomy was performed by robotic surgery. Obviously, after such a surgery, there's definitely a recovery period. But basically now, 3 years on, I can do everything that I did before. I lead a very normal, active life. I go to the gym, I attend boot camp, I travel. One difference is I'm not a real fan of running for long periods of time, because it does make me feel like I need to go to the bathroom. And if you've run a long way from home, it's a bit far to get back to go. I'm conscious of how much water I drink during the day. I make sure that I now drink plenty of water to keep everything moving and everything flushed out during the day. And I sometimes have a problem with my neobladder leaking. It can leak, especially at night, but that's also dependent on how much I've drunk in the evening. Really, I've just adjusted to what is now my new normal. I'm just conscious to make sure I go to the bathroom regularly throughout the day. And if you were to see me, you would never know that I've had this major surgery. I do, however, now appreciate every day and just all the little special moments in each day after going through such an experience.
Carly, you're muted.
I just want to say thank you for being an ambassador for bladder cancer patients all across Australia and all the great work you're doing for this great cause. I wanted to ask, we have Helen Anderson, she's a cancer care nurse. We had a question asking what kind of support can cancer nurses offer bladder cancer patients?
Thanks, Kelly. I guess it varies at different health services as well. So I'm just going on my own experience. The cancer nurses can work in either the surgical side of things or they can work in the oncology side of things. So they'll either support patients and their families that are having surgery and going through all the surgical treatments, or the focus will be on supporting patients and their families that are in the oncology area, so having chemotherapy or radiation oncology. And I guess one of the biggest things for our role is coordinating between those services as well, to make sure there's a smooth transition for patients that are might be having neoadjuvant chemotherapy, going to surgery, and it's just to make sure they've got that ongoing follow-up as well. So that's quite a big part of the role. and also just guiding patients with all the information that they're given. So, you know, everyone's talked about all the treatment decisions that patients might need to make, and it's helping patients understand all that information. We've got probably a bit more time than the doctors have got in the space that you're in, to go through those things, and patients have got us as a contact then to be able to ring and ask all those questions that they might have had. You know, numerous things come up, they've left the clinic and they've got certain questions, so we're that main contact for those patients as well to ask those questions, and just making sure that they've got all those other health services they need as well. So, you know, dietitian, stomal therapy nurse, any community services, just making sure that we link patients and families in with all those extra services as well.
Helen, in some patients, unfortunately, you know, we've tried everything we could do, and the cancer has unfortunately, you know, spread throughout the body, and that would then be called metastatic bladder cancer. When is the most appropriate time to refer such patients to what we call a palliative care service?
So the sooner the better, and I think there's a lot of evidence out there to suggest that the earlier that patients are involved with palliative care when they're diagnosed with metastatic disease, the better quality of life they've got, because their symptoms are managed a lot better. But I think the most important thing is to ease into that discussion with the patient as well, which is, you know, just explaining what palliative care is, because a lot of patients do get frightened when they hear the words palliative care because they don't quite understand. They think that that's just end of life care, that that's just the last few weeks of their life, but actually, you know, seeing them months in advance is really good because they can start managing their symptoms early on and have those discussions about health directives and, you know, getting all the paperwork as well sorted out, which is really important. So, you know, getting all their finances, their wills and all that information sorted out early on as well. So the earlier the better if possible. Yeah.
Thank you, Helen. Patricia had a quick question.
Yeah, I guess we're often trying to transition palliative care involvement as early as possible, because we want the patients to have had time to develop that relationship with the palliative care team and not be someone that they've never met before coming in when they've really not got very long to live. So it really helps the family to have met the palliative care nurses, the patients to be comfortable with their role. So we have them involved, overlapping with us even during chemotherapy if their symptoms are really bad and hard to manage, and we're finding they're calling us for you know, morphine prescriptions, anything like that, where we feel that they could be managed better by more regular contact. We try to encourage linkage to the to in our area it's called the Calvary Palliative Care Team, but to their local palliative care hospital. And there might be periods of time where palliative care is very involved because they've got lots of symptoms, and then things settle down and they back off again and they're not involved, but at least they're linked in, and when things do get bad, they know those nurses, they have the numbers to call, and they're comfortable to use their services.
Thank you. And Professor, we haven't, Simon Wilcock, we haven't forgotten about you. He's our GP on the advisory team. Lisa had a question for you. Is there, or was, sorry, what is the most common age group that develops bladder cancer? And is it, I mean, traditionally it was thought to be in men only, but we can see here we have a lot of women that are getting it as well. Can you speak to that?
Excuse me. I'm not an epidemiologist, and Manish and David could probably answer that even more accurately. But from a primary care perspective, we certainly see this as a disease for the sort of second part of your life, if you like. Would rarely see it in a patient under 50, although that's not impossible. And certainly we see many women who are affected with bladder cancer as well as men. I think the pattern and the epidemiology of bladder cancer has probably changed over the last 50 years. And that probably reflects certain social changes in terms of exposures to the sorts of carcinogens and things that were traditionally associated. There were certain industries and dyes and chemicals that were associated with bladder cancers that are less common in the community now. And I think we see more bladder cancers that are just sort of sporadic rather than caused by something else. I guess the other point I would make, and listening into this panel discussion, it's been very interesting. I think for somebody who had a new diagnosis of bladder cancer, it would probably be quite terrifying to think, now I'm going to have a cystoscopy. That means an anaesthetic potentially, not necessarily, but every 3 months, and then every 6 months, and that's going to go on for years and years. And I'm going to have treatments that might give me symptoms. Part of the role of the primary care doctor, and the great thing for me is that I don't particularly make the decisions that have been discussed tonight, because there is so much expertise that's well represented on the panel. Where I can help the patients is how to factor that into, I think Christine, you used the term new normal, which is where we want our patients to end up. We want them ultimately to feel like they're living life, whether that life is going to be extended for many years or only a short time. We want them to be getting the most out of it. We want them to be managing the other comorbidities they have. Once you're over 50, you might quite likely to have other diagnoses like diabetes and things like that you're managing as well. So I think what we would see from a primary care perspective as a successful outcome is the bladder cancer well managed, and we've got the great team here tonight who can ensure that, but also that the patient's quality of life and that they feel that they're in control of the cancer rather than the cancer is controlling their life and the treatment for the cancer. A lot of psychological support necessary, and I'm sure the people on the panel tap into that as well, commonly associated with depression and anxiety, but also questions around sexual function and those sorts of things. And part of the role, I guess, of the team, but also me in primary care, is to make sure that those resources are all available to the patients as well. But David or Manish, you may want to talk specifically about sort of who gets bladder cancer and then at what age.
David, do you want to comment?
Well, I agree with Simon, and actually Manish and I have done a little bit of work on the changing pattern of that in the past, but it was traditionally a disease of men over 50, industrial workers, smokers. That pattern appears to be changing. That's transitional cell cancer. There are some other rarer forms of bladder cancer as well, which have less clear causation. But one thing that's found out in most Western countries is that the incidence in women appears to be increasing, and particularly in older women, where they can come into actually worsening of prognosis. Management might want to say something like that, because we looked at that 2 or 3 years ago, but it does seem to be shifting more away from the 5 men to every 1 woman to a slightly more women, and probably more aggressive cancers in women as well that are occurring. It may be that women started smoking more frequently 20, 30 years ago, which is the time it takes for the risk factors of bladder cancer to come through. But there's obviously been a change in profile. It still is a disease of older men still, but there's other groups coming in there as well to challenge.
Professor Patel?
Yeah, so we made an interesting finding, which is while the prognosis for women appears to be getting worse compared to men who appear to be getting better, it's really the women over the age of 70 whose prognosis is getting worse. And we're thinking that it might be related to hormonal status. And there's some evidence to suggest that hormones might be protective for women before menopause, but once they hit menopause, that protection is lost, and hence when they do get bladder cancer, it tends to be quite aggressive.
Okay, thank you. I want to go to some of the live questions that have come through. Manish, you're not out the woods yet. There's a test called CX Bladder test. There's a lot of people get sent to the test for bowel cancer in the mail. Why can't we get something like that, something simple where we can check to see if we have bladder cancer? Is this one of those tests? Is there a role for this test in diagnosing bladder cancer or staging?
Yeah, so the CX Bladder test actually originated out of New Zealand. It's a very good test, but the whole idea about all of these non-invasive tests is that we're trying to replace cystoscopy, because cystoscopy is very expensive, it's invasive, patients need to sometimes have an anesthetic, etc. Can we get rid of a cystoscopy with another test? And CX Bladder is just one of many tests that have been tested to see whether we can. And while they are fairly good at picking up bladder tumors, they're really not sensitive enough at the moment to be able to get away with cystoscopies. So the answer is yes, CX Bladder is very good, but in follow-ups, which is really where it's been tested, it's not good enough to avoid a cystoscopy. So we still need more research to be done. As far as I'm aware, Cxbladder has been used to diagnose, but again, the results haven't been as good as we'd like them to be. So we can't, again, do away without a cystoscopy.
Thank you. I have another question. I am having ongoing shortness of breath and severe heart palpitations as a patient who's started during his 6 BCG installations. I've had repeated tests to try and locate a reason for these symptoms, but everything is okay. Again, this only started with the BCG. My specialist and oncologist confirmed this could be side effects of the BCG. My question is there any evidence these side effects from the BCG will last long term? It has been 18 months since my 6th BCG. I'd imagine, Patricia, that's a question for you.
Yeah, sure. And they're not side effects that are commonly seen with BCG. And I literally can't think of one person who's had breathlessness or palpitations secondary to their treatment, apart from perhaps like a slight reaction when the treatment is happening. Like, you know, while they're in the chair or in the chemo suite, obviously you can get an allergy to any drug and have those kind of side effects. But usually you'd expect that they would settle pretty quickly if it was that kind of allergic reaction. And I'd certainly be looking pretty hard for another cause of the breathlessness and palpitations.
Yeah. If I can dive in there, that's what I would say as well. And we have to remember that while the focus has probably been the bladder cancer for this patient in the last 18 months or so, they're in an age group where other pathology can happen too. And as their GP, I'd certainly be looking for other causes of those symptoms, particularly getting a cardiac check. It may be something that's very manageable and treatable, but it needs to be checked.
Dr. Bastek, another question came in about from an anonymous attendee, how often should BCG treatment be given? I know that's like asking how long is a piece of string.
I guess it's hard to know exactly what they meant by that, but the standard when you're starting your treatment, we call it an induction course of BCG, is usually once a week for 6 weeks. And we ideally would like patients to try and hold it in the bladder for up to 2 hours. Some people can't hold for that long if they've got a lot of urinary frequency, and maybe an hour, hour and a half so they can manage. But if that's what they kind of mean by how long is it given for, it's usually 2 hours would be standard on the day, weekly for 6 weeks, but maybe some breaks. And then in terms of, it could be how long over the years, I guess it can be up to kind of 3 years of the maintenance treatment given less and less frequently over time. I guess if the anonymous attendees online wanted to elaborate and want a little bit more detail on exactly what they meant by that, we can certainly answer.
Sure. All right. Here's a question. This can go to anyone who puts up their hand. Can the panel please comment on sexual health support that's given to patients who have had radical cystectomies specifically, although I know radiation can also affect sexual function, and maybe an area of improvement. So I'd imagine a nurse could answer that, and a urologist could probably answer that question. As we know, with the radical cystectomy, the bladder comes out, and in a woman, the ovaries, the uterus, part of the vagina. There's a lot of nerves down there that are supplying the sexual organs, so they're obviously at risk during that surgery. Do one of the urologists want to contribute?
So Carly, I might address that one.
Yes.
The first thing we need to talk about is the actual surgery. So the surgery, at the time of surgery, we need to know the patient's preferences. And if they want to maintain sexual function, you can actually modify the surgery to try and ensure, or at least increase the chances of getting sexual function afterwards. With a male, it's important to preserve the nerves that sit around the prostate. And over time, hopefully those nerves recover and the patient can regain erections afterwards. In general, if you do save nerves in someone who has normal erections, the erection rates are up to about 70% after surgery. In women, it's important to either preserve the vagina if you can from oncological reasons, or reconstruct it in a way that you have functional size. But also another important thing with women is that they have nerves that need to be preserved as well, which lubricate the vagina. And it's important to preserve those. at the time of surgery.
Okay.
Maybe we'll let one of the nurses comment on the help afterwards.
Yeah, and then maybe couple counseling, or there's any, or even Simon maybe can comment there. Helen, were you going to say
Oh,
something?
sorry. I was just going to say, when at the hospital I used to work at, we did have a men's health clinic. I mean, it was really obviously for the men. We didn't have a women's health clinic, but they did a lot of work with men who had lost their erectile dysfunction. Unfortunately, it wasn't a free service, and I think that's can be a problem at the moment, trying to find a service that is publicly funded, because a lot of these services are privately funded, so patients have to pay for the service. And it's the same with, I think with the injections and things like that, it's not necessarily funded as far as I'm aware. Am I right? Speaking with the urologist.
Anyone want to contribute?
Yeah, neither the PDE5 inhibitors or the intracavernosal injections or the penile prostheses are funded.
I think the important thing with this question is that it is something that we should think about. It should be automatically raised with the patient early on in terms of as part of their treatment and part of their management and getting back to normality. And the value of having a team of people looking after you is that we will talk among ourselves, we'll identify the local resources, we'll identify costs and things like that, and much more than as any individual on the panel here being able to say this is what you have to do to get the team to work on that. I know in Sydney we would probably be able to access resources that were both available and at a reasonable cost, if any cost to the patient. And I imagine that would happen in many other sort of communities around Australia as well. But very important, the first thing to do is to ask about to raise the issue with the patient, because some patients
cut yourself off early. David, yes?
I think the brief answer is that both for men and women in bladder cancer, this is poorly provided for and ought to be better options. It is difficult to access. It's often not discussed in my experience, both particularly with women, and I think there's need to be more of a focus on this before the treatment and with services afterwards as well. Yep.
Amy had some input.
David basically said what I was going to say, but I think communication is really important in terms of expectations about what to expect after treatment, and to ensure that, one, if you're having difficulties, that you communicate that with your specialist or your GP or your nurse that's looking after you. One resource that may be useful if there's not an appropriate local service is to try the Cancer Council helpline, which has links in with Beat Bladder Cancer as well. Problems with sexuality are very common after any cancer treatment. So the nurses who are available through the Cancer Council helpline are very used to talking about those issues and can be a really good resource.
Thank you. David, Professor Gillard, at least, what is the relative success rate of finding and treating bladder cancers early?
That's a very difficult question to answer, because it depends what sort of bladder cancer. As you know, bladder cancer, first of all, I guess we talk about transitional cell carcinoma, which accounts for just over 90% of them. If you get a low-grade papillary, non-aggressive tumour, small one, and you cut it away with a telescope, more than 95% never come back again. If you get high-grade cancer, whether it's invading into the bladder or it's just sitting on the surface, the relatively higher proportion will progress and need more aggressive treatment. So I don't think that's a question you can answer with one simple answer. It depends on what sort of bladder cancer you're dealing with.
Okay.
You need to make sure somebody's looking at not only the prognostic features, such as the grade of the cancer, how far it's gone in terms of growing into the bladder, but also, in many cases, how it behaves is the strongest indicator of how it's going to impact on your future.
Well, let's expand on that. Claire's commented that her husband is 45 and was recently diagnosed with a high-grade T1 tumor. Have there been any studies into the outcomes for this age group in terms of recurrence of tumors and long-term prognosis?
Well, there have been studies into the outcomes of tumors, and if it's a high-grade early invasive cancer, it again depends on whether it's a single tumor or whether it's multifocal, for example, where there's multiple tumors, and whether it tends to come back fairly quickly. the multiple ones and those that recur have got a far worse outcome unless they're treated earlier and more aggressively sometimes. I guess in historical studies, 45-year-olds were quite a small percentage of the patients with those sort of bladder cancers. So there's no great evidence that age impacts on the behaviour of the cancer. And it would be impossible to give any study with a large number of people in their 40s with that type of cancer, I think, unless Manish is aware of one.
Or Patty, Dr. Vastek is putting up her hand. You've got something to say?
Yeah, I was going to kind of reiterate basically what David said, is that obviously the data we have across the board for any T1 high-grade tumour would have included people in their 30s and 40s in those studies, but they would have been a small proportion of the patients. So it'd be hard to tease it out and say what the outcome was for a 45-year-old versus a 65-year-old. But we certainly would treat far more aggressively and really try to encourage someone to go through their maintenance. We'd watch them more closely, and we'd have a much lower threshold for considering cystectomy early.
Claire has said that her husband's tumour is a single, must be papillary lesion, and it's transitional cell. How does that affect the outcome?
I guess that it's better, much better than being multifocal. And if it's been a single occasion so far with no actual recurrence, then hopefully the outcomes are still good. He'll just need to be obviously monitored very closely given his young age.
Okay, questions are coming through second fast. So back to Dr. Bastic again. We had the anonymous caller had asked about what is the most effective maintenance protocol for BCG?
Yeah, there's a couple of different maintenance protocols depending on which study you follow and which country maintenance protocol you want to do. We follow one called the SWOG protocol, and that looks at two different groups of patients. So those that are low risk would have the induction, which is the weekly for 6 weeks. And then over the next 12 months, they'd have 3 consecutive treatments a week apart at 3, 6 and 12 months. And that would be considered their full maintenance then for 12 months. But if they had high-grade features or multiple recurrences, we aim to try and get that maintenance going out to a maximum of 3 years. And so after that first 6-week course, treated at 3 months, 6 months, and then 6 monthly for a further 5 cycles. So there isn't really, I guess, an optimal one. It's best that hospital by hospital we choose one that we're going to follow, just so that everybody's doing the same thing and can reassure patients and make sure they're not getting confused by multiple schedules. And that's something we had to do a couple of years ago because different clinicians were doing different things. Some studies looked at 1 treatment a month rather than this 3 in a row for 3 weeks. So I guess there's multiple different maintenance protocols, and as long as one is being followed based on some reasonable evidence, there wouldn't be a one-size-fits-all.
Do you suggest having the flu vaccine while receiving BCG, or wait until the treatment's complete?
I can't see how it would really be impacted by BCG. So if the GP is recommending the flu vaccine, I would absolutely be happy for them to have it during their treatment.
Mm-hmm. Is there a role for gemcitabine in bladder cancer? I know there's some trials that have been looking at gemcitabine. Can you tell us some more about that?
Yeah, so that's something we're having to think about in periods of time when the BCG shortages happen. So gemcitabine is a chemotherapy agent that is very effective in treating bladder cancer that is more advanced than the early. So it can be, if it's a muscle-invasive bladder cancer, we might use it before or after a cystectomy, or even in people where unfortunately their cancer has recurred or spread somewhere else. Gemcitabine is a very active agent. So we do sometimes use it as an alternative to the BCG to give intravascularly, so straight into the bladder. The evidence is not as strong as for the BCG, but it certainly seems to be quite effective and well tolerated. And it's a reasonable alternative that's actually funded by the PBS. So in someone where paying for the mitomycin might be out of the realms of possibility, because it's about $500 a dose for the 6 weeks, we'll often use gemcitabine as an alternative.
Amy, you've been involved in some clinical trials. What happens if a patient wants to get onto a clinical trial or find out more information about it? Can you tell us a little bit more about that in Australia?
Sure. The first thing would be to talk to your doctor. So they'll be your first resource for letting you know what clinical trials are available that might be suitable for your particular stage of bladder cancer. There are a couple of online resources that you can go to. There's a website called australianclinicaltrials.gov.au where you can search by disease site. It's not super friendly and it's difficult to find the trials that might be open in your area, but it is something that you can have a look at. The other website that is worth going to is the website for ANZUP, which is the Australian New Zealand Urogenital and Prostate Clinical Trials Group. So this is the clinical trials organisation for Australia and New Zealand that runs trials for bladder cancer as well as other urological cancers such as prostate, testis and kidney. And they've got the listing of their ANZUP trials on the website there. One of the interesting trials that they're running at the moment which is Australian-led, is a trial which is looking at whether adding an immunotherapy agent to a combination of chemotherapy and radiation, muscle-invasive bladder cancer, is safe and feasible. So that trial is still open in Australia at the moment, as are several other trials.
Oh, thank you for that. We are coming to the end of our session. We have 1 or 2 more questions left. If you have any final questions that you'd like to ask in the Q&A, please send them through now. The next question I'll direct to Professor Gillett, and it's asking about when you do a cystectomy in men, does the prostate have to come out? Is that routine practice?
In general terms, yes. I mean, bladder cancer is felt to be a disease that has a field effect. In fact, the whole lining of the bladder and, in fact, the inside of the prostate and the urethra is the same type of cell. So the standard treatment is to take the bladder and prostate out. And in some men with multiple tumours, even take the urethra out. However, there are a group who've got single solid tumours away from the bladder neck who you can justify occasionally in younger men leaving the prostate or part of the prostate behind to preserve some sexual function. It's probably a relatively small group, but I've done it on a few occasions. So the standard treatment is to take the prostate out with the bladder, and it has to be a very particular circumstance where you may consider leaving some of the prostate capsule behind, or very occasionally even the whole prostate. And that's usually probably in some of the less common variants of for bladder cancer rather than the normal transitional cell tumours. So the answer is yes, usually it is necessary to take the prostate out.
Thank you. Does anyone else have anything that they would like to contribute or add that we haven't touched on during our session out of our panelists? Hands up. Yeah, Amy? Yes.
I was just saying thank you, Callie, for hosting.
Oh, it's my pleasure. I'd just like to say it feels like this is like a meeting, a multidisciplinary team meeting that we have at the hospital. Patients out there, this is what we do when we decide about your management, what's best for you. We sit as a whole team, as we've done here, and then we discuss what's your best way forward. This is exactly how it's done. And we hope to have more of these sessions in the future. We've had an amazing response. We've had maximum of 54 participants during this session, which is unbelievable. And we know that our participants have come from all the way from Western Australia and Perth to Brisbane to Melbourne. So it's been quite amazing, an amazing session. And we really hope to do it again. We also want to let you know that we are running bladder cancer support groups. We have a face-to-face group in Sydney. We've done Zoom sessions, and we're hoping to expand. So if there are nurses or patients out there that are interested in driving the process, you don't have to be qualified in anything to do it. You just have to be interested and enthusiastic and passionate, and we'll train you up. We'll support you. We'll provide the materials you need, the promotional marketing materials, and we can help you with speakers. As you can see, we have a really strong advisory team made up of very well-renowned leaders in the field of bladder cancer in Australia, sitting right in front of you right now. You can email us at any time. The email address is the same one we've been using. Christine, you want to tell us some more?
Yeah, the email address is support@beatbladdercanceraustralia.org.au. Email me anytime with any question and I will get back to you.
Yeah, we can ask any of our panelists any questions at any time, so feel free to ask anything and we'll get back to you with an answer. If there's no more questions in the Q&A that have come through, there aren't, just some praises. Thank you, we appreciate it. Thanks for joining us this evening. Thanks to our panelists for taking time out of your evening. We know you're very busy, but we appreciate your support and your time. and we'll see everyone again soon.